who's hurting, to those who've had enough, to all the undeserving. That should cover all of us. And please do not let go.
Hello everyone, welcome to Time to Heal. My name is Pam Hemphill, and I bring you the dark side of addiction to a whole new light by providing you with some solutions on how we stay clean and sober one day at a time. I want to start off by sharing with you that heroin use has been on the rise since the year 2006. In 2012, the National Survey on Drug Use and Health reported an estimated 69,000 heroin users. That increase was mainly driven by young users in the age bracket of 18 to 25 years old. Additionally, from the year 2002 until 2012, the number of people diagnosed for heroin dependence or abuse has doubled from 214,000 to 467,000 people. Young people in that age range who have sought treatment for heroin abuse has increased from 11% in the year 2008 to 26% in the first half of the year 2012, and this is 2014. So it is really getting to be a terrible epidemic out there. There's an old stereotype about the opiate addicts, painting them as an old school street junkie who overdoses in the alleys and they got needles in their arms. This stereotype is not only wrong, it's dangerous. It defers people from recognizing the new opiates, especially the prescription painkillers and their non-medical use. And the new opiate addicts who are 30-something of age, largely employed and spending 1/3 of their annual income supporting their opiate addiction problem. So today's discussion is how we are treating the opiate addict, and specifically at Bull Creek Treatment Center here in Boise, Idaho. I have two guests with me today. First, I have Don Tennyson, also known as
Chicano Don,
and who is the Executive Director at Bull Creek Residential Treatment Center, and Mike Biggins, who is the Treatment Supervisor and the Program Manager there at Bull Creek, who are going to break down to you today the different types of treatment that they offer at their treatment center. So I want to start off by asking Don, can you give us an overview of the different kinds of treatment that you provide for alcoholics and addicts at your treatment center?
Well, I will, and I'm glad you started us out talking about how much growth is happening on a daily basis with the opiate crisis we're in. We just ended the meth crisis, and now we're in the opiate crisis. And in my view, it's going to be, and it was already bigger than the meth crisis. And so if you remember how big that was, the opiate crisis is going to be twice that size. You know the analogy of tip of the iceberg, that when you see an iceberg, you're only seeing the smallest part of it above water. The biggest part of the iceberg is under the water, and you don't see that. And that's a good description for what's going on with the heroin opiate abuse in our country, especially in Idaho. The biggest part we're not even seeing yet. And so we look at a lot of treatment centers like Bull Creek that are overwhelmed with admissions with opiate addiction, people wanting treatment because they can no longer control their addiction. They just begging for have their life back. And as your statistics pointed out, many of these people are working class people, professional people that have just lost control over their life, and they want it back, but they don't know how to go about that. So what I like about Mike being on the show today is that he can drill down a little further as to the daily treatment going on at residential programs like Bull Creek, and he can let us know and let the audience know specifically the modality, the type, the approach. He can maybe even address the treatment regime a little as to what kind of schedule they're following. Because as you know, most addicts, they end up in a dysfunctional way of living. And part of residential treatment that we don't talk enough about is once you're in a residential treatment, you're automatically putting more functional behavior in the addict's life. We're not, the counselors are addressing the dysfunction. The counselors are addressing how they have to get back on the path of recovery so that they're not living in a dysfunctional way. Because you take the drugs out of them, and the dysfunction's still there. And that's where the treatment, the counseling piece can also help. What I love about Bow Creek Mike's approach is he has a medical component, one of the few residential programs that I'm aware of where they can take an opiate addict who is still using and bring them into treatment and use medication to stabilize them and then take the treatment approach. And so I'd like to pass the baton on to Mike and let Mike begin to describe and answer your questions about treatment, as at the kind of treatment modality that he uses and with opiate addicts and others.
Okay, Mike, can you share with us what some of the practices that you use there at Bow Creek?
Well, and I think Don had begun to speak to it. We have the medical component that we tie in with counseling, and what we know to be true is that if we pair the two, outcomes are increased. And I know we're talking about opiates, but our medical component, we actually use medications for a variety of drugs. Tobacco, for instance, which is oftentimes overlooked. Mm-hmm. It's not at all unusual for somebody to be on lozenges or gum or Shantex or something similar. And the reason that we're seeing this is that we're witnessing a change in the way that we have approached treatment. Historically, it's been abstinence-based. We pull you away from the means to use, and then you go through whatever pain and suffering there is, and then we will hammer away with some modality or some philosophies, and that's supposed to heal you. But just like with any other medical condition, the more we know, the more approaches that we use, the greater the multidisciplinary team, better the opportunity for success.
So you're absolutely correct. You are meeting them where they are,
Absolutely.
not where you think they should be.
Absolutely. Very client-centered. Bow Creek is client-centered, client-driven. We have amassed a staff out there that's absolutely amazing. And so everybody is on board with this idea that we meet clients where they're at, and then we work with them on modifying behavior. Now, Don spoke about the dysfunctional behavior, and that's maybe the cornerstone of our program, is we don't punish addiction. We recognize addiction as a disease, but we modify the addictive behaviors that have come along with the addiction, the parts of a person's life that have modified slowly over time that move them in a direction that is not them. So we never ever attack the addiction, but we treat it, and we work on modifying behavior daily. As a matter of fact, 36 hours per week at Bow Creek is dedicated to treatment groups. Plus we have individual sessions, access to medical, 6 days a week on-site presence, 24 hours a day, 7 days a week on call. So there's really very little that a patient can experience that we can't address with them right at the moment of crisis, assisting them to apply skills, treatment philosophies, and get moving in a direction where they are self-soothing and addressing their own issues and making positive choices.
Can you break that down a little more for the audience? And Pam and I, we talk about best practice, science-based approaches in today's modern day treatment. When we talk about best practice like relapse prevention or MRT, can you break that down for us? How is that utilized in your treatment regime, and what does that look like? How do the patients get that?
Sure, absolutely, and I love that piece because we do talk about best practices. Best practices are research-based programs that we know work. And Don had talked about relapse prevention, which is universal. We've used it for decades. MRT, matrix, dialectic, cognitive behavioral therapy. We use programs that we know have proven results, and we apply those programs individually. So we may very well have somebody who comes in and needs mindfulness as opposed to cognition. Somebody who is coming in as a part of a criminal charge, who needs moral reclamation therapy. Definitely everybody is in early stage recovery with us, so it's always matrix model, redundance, scheduling, life skills, self-care, hygiene in some cases.
Oh, this is just wonderful hearing about this because, a lot of treatment centers are so cookie cutter. Knowing that you're offering all these different various things for someone, a holistic approach. That is so encouraging. Another question I have for you, is treatment different with a heroin addict versus an alcoholic? What's the difference there?
And that's a great question. So we look at addiction just as the medical field looks at it. So everybody has a diagnosis based on their dependence. So we would not necessarily approach alcoholism and opiate addiction identically. We would recognize that there are varying experiences, varying problems that people have experienced.
Symptoms.
Yeah, symptoms.
Yeah, I've heard, just like to ask both of you this question. I heard if a heroin addict is in detox, detoxing, and an alcoholic's detoxing, that the alcoholic could die physically.
Mm-hmm.
Yeah, alcohol and benzodiazepines, that's what somebody can die detoxing from.
Are you providing detox there per se, or you are?
We do. We do have a moderate medical detox. So there is, based on our medical team's perception that it's safe for them to detox in a facility, they definitely do.
Is a nurse come in and see them, or?
Nurse, medical doctor.
Wonderful.
Yeah, and as a matter of fact, we have not only nursing that's there, we also, one of our nurses is 1 mile from the facility, so she's quicker than emergency response should the need arise.
So that would be the difference. You look at first the medical aspect of what they need in order to detox. You take that part first.
Yeah, the doctor has standing orders for the facility, but once they arrive at the facility, Mike and his team, the nurse, they take a hands-on approach with the patient, and they're evaluating the new admit right away. For example, like you mentioned, we know that if they have a history of DTs because they're alcoholic, that makes them at a higher risk, and we need to get them on medications to prevent going into DTs or having seizures from the withdrawal of alcohol. As you mentioned, alcohol withdrawal can be life-threatening. And where life is threatened with opiate addicts is from overdose. I don't know of any case that I'm aware of where someone dies from the withdrawal of opiates. They die from the overdose of opiates, but an opiate patient going through withdrawal is much harder for the clinicians to deal with because they're as sick as one can be, and they can't stand being in their own skin. They're much harder to manage, whereas the alcoholic in withdrawal, they're not behaving wildly unless they're in DTs. But one of the things Mike's team does and the doctor does is they assess before they even arrive. Is that the kind of history they have? So then what happens, Mike? What happens after they're placed in there and there's evidence that it's safe to put them into the population, so to speak? And I'm going to digress. What is relapse prevention? What is MRT? The people in the audience may not know what that is. Well, how do you teach that? What does it look like? What does the patient get out of it?
Okay. So let's start with relapse prevention. And relapse prevention is exactly what it sounds like. We work with patients to determine what causes them to attach emotion to thinking, what causes them to be triggered by a desire to use, which becomes then typically a craving, an internal force that says I have to use. So we work with all of our patients to determine the course, what we would call the process between thought and action. Relapse prevention is then creating a plan, and actually a comprehensive plan, to reduce the opportunity for relapse. Really starting with removing the means. And we always say people, places, and things. That's what you have to change, is all the people, all the places, and all the things that are associated with your use. Get rid of the means, the opportunity to use is lessened. And then of course, it's comprehensive, so it's more than that. It's much more than that. It's about emotion. It's about holidays. It's about success. It's about failure. When somebody uses, and for the most part, the folks who are coming to our program have at least a 5-year use history, and oftentimes decades. So every experience they've had in that time was also associated with use. So everything is going to lead to a thought process of use.
So you help them identify what their triggers are and what their warning signs are. So when they do leave your facility, they have that awareness, so they could be more mindful to modify where they're going and who they're talking to. Is that what you're
Yeah, it's very well
sharing?
put. That's exactly it. And I do want to just jump back and say that in treating alcoholism versus opiate addiction, we have always felt that it was all right to medicate for alcoholism. Now, it started out with maybe an abuse, so you'll get sick if you drink, but there's this idea that medication was appropriate with alcoholism, at least in some format. What we find oftentimes with opiates is there's a resistance to providing medication. And with opiates especially, it's not just brain chemistry that's affected, it's also the opioid receptors throughout the body. So it is extremely painful. Sensory pain is changed, the way they think is changed. So the opportunity to provide them a medication that allows naturalized brain chemistry so they can start reassessing their life is important and beyond important, something that we actually need to embrace. The idea that we can pull somebody from a 20-year opiate use, bring them into the facility, get them stabilized, and actually have them addressing emotions and behaviors within a 7-day period is really unheard of. Because we could be looking at 7 to 14 days of severe withdrawal, as Dawn was expressing, where they're just beside themselves. Everything is crisis.
Oh, yeah. Okay. And family, how is the family involved?
So family, we integrate the family absolutely as much as possible. We have the conversation with patients, and again, client-centered, patient-centered. So usually through the door, that's one of the first conversations we have. Oftentimes families with them, we have that conversation with everybody included. At least once a month we have a family group, which has been just increasing in attendance over the course of the last several months. We have started to use technology. Of course, we have phone conferences if people are out of state, but we also try and use Skype and FaceTime and another number of things that allow at least face-to-face contact. Family sessions are important. This is a family disease. We drop drugs and alcohol inside of the family, and the family's behavior modifies. And once it modifies, everybody has to heal. To bring the family back together, everybody has to be working on themselves. And we recognize that as a truth. The true recovery is the family has to heal.
Yes, because you know the myth, or what I've seen, is family drops them off, fix them. I'm okay. They've got the problem.
Yes.
But we got to address that.
Yes, and I think we do a great job at Bow Creek of that, because we bring, again, the family in right away. And we work with the patients to really express the need for family. And of course, as you can imagine, families are destroyed, not just injured, but in some cases, I mean, absolutely destroyed. So we want the family involved. We want this holistic approach. And holistic is not just grab a patient for 28 days and keep them out of society. It's restoration. It's restoring everything that we possibly can with them.
Yes, absolutely, because they've been told by the addict or the alcoholic, it's your fault. If you had done this, if you had done that, I would be okay. And so they've got a lot of stuff going on inside them. They need that help.
And if I may throw in another way to look at that too, is his team very successful in treating somebody, and they graduate and they're on fire with their new life and their recovery, and they go home to a family that's still dysfunctional, we've just set that patient up for failure.
Exactly.
So it's important. And when I said to you earlier on other shows about modern day treatment with modern day addicts, when he mentioned Skype, that's an example. He's not leaving out the family that can't come. They're getting help through his team, even if they have to use Skype. I'm impressed with that.
Yeah, I've never heard of that before. That's wonderful.
So the beauty of where we
Yes.
are now, and then
Yeah.
I've had the opportunity to talk with many people. We see online group sessions. So bringing the family in is important to us. It's one of the mainstay philosophies of Bow Creek, and so we do exactly what we need to do to make that happen.
Oh, that's right. I have another question I want to get to. We're getting closer here to our end of our
yes.
time, but I want to make sure I ask you a few more questions here. What would you do to improve treatment or alcoholism, and what would that be?
So if I could improve treatment, first thing I would do is I would free up more state and federal dollars so that we can actually have people access treatment.
Yes.
And then the second thing that I would push for would be that we start moving in a direction that is truly what we say, which is best practices. Best practices sometimes are limited to the things we want to force inside of our program, because there will be a best practice that we can say this is what we're using, but best practice should be research-based. And if we know that we need to provide life skills to the 18 to 20-year-olds, as well as opiate specific relapse prevention, as well as life skills, that's what we need to be doing. Is we need to be opening up our minds. We need to move beyond this idea that we can just force somebody into this particular program and that's going to sober them up. And really moving into that is where I would love to see us. And we're there. We're moving in that direction. But change takes time, and we still are fighting the stigma of drug addiction. We still want to criminalize that. As long as we do that, treatment will be much more difficult.
Oh, so true. And Don, how do you feel about this?
Well, one of the things I'm excited about with MAT, medication-assisted treatment, even though it's not embraced here, it's beginning, the awareness of it is beginning. And I think that's going to cause treatment in the Northwest to get better. Because then what we're doing, we say alcoholism is an illness, a progressive, fatal, incurable illness is what we used to say old school. But if it is truly an illness, and we say addiction is an illness of the brain, the central nervous system, if it truly is an illness, then it stands to reason to treat it medically. And Mike alluded to that. And what I like about MAT and what's happening in the field, even though it's happening very slowly here, is that the medical piece is becoming more and more important in treatment.
Yes.
And so there should be a marriage between clinical and medical. And that marriage, as Mike alluded to, needs to be a healthy one. And the more that marriage happens, the better treatment can happen. Mike also mentioned a few minutes ago about what I call old school treatment. And they come into treatment and we try and convince them to stay clean and sober. You know, you just need to not use.
Yeah.
And for some people, they need medication to stabilize them long enough for the counselor to get through to them and their denial and resistance to recovery. So medicine is a very important piece in modern day treatment.
Oh,
And I love that piece, and I'm so glad that you brought that up, because I've worked in the field for the last 3 years, I guess now, where we've always used medication. So sometimes it's lost on me that there's a number of facilities, likely everyone except for 3 or 4 inside the valley, that don't use medication. Bow Creek, we definitely have the medical component. We have an addictionologist who determines what the best medical practice is, and in often cases with opiates, an opiate addict, it is Suboxone and methadone.
oh, I'm so glad you both mentioned this, because that is really what is starting to happen. We're getting a more open mind. We're listening to the professionals. And hopefully, you know, with you two coming on today and sharing this, more and more people will get a better understanding of what we need to really be able to help the heroin addict that's suffering today. I really appreciate both of you coming on today. You know, you're a blessing to the community.
I
Appreciate
know
what you
I'm a
do.
blessing to him.
Yeah, that's
Yes, it is a blessing. Thank you very much for having
yeah,
me.
really. Seriously, what you're providing is just wonderful. I just want to share a little something here before I end. Well, to my audience, I want to thank you for joining today. And please be sure to watch our shows on YouTube and join Time to Heal group on Facebook. I also want to again thank James and Karen Blair for a song that they donated to us. And I want to thank Monty Meyer of Take 12 Radio for all his support. Will you please join me and thousands of others of what we talked about today and be part of the movement to get rid in our society the stigma about addiction and addicts and heroin addicts and alcoholics as people who need help. It's more of a medical problem, not a moral problem. Wouldn't it be nice if everyone would look within their own hearts and realize that all human beings have obstacles and challenges to face? Together, let's raise the awareness from the moral issue of what's right and wrong towards a healthcare issue, that people can have some healing and some hope back into their life. Also, if you would like more information about the Bow Creek services, you can call them, and their number?
The number is 208
459
1883.
And don't give up, because your miracle is on its way.